welcome to another installment of DCEO's Healthcare Breakfast Panels. I hope this virtual panel finds you with a warm cup of coffee and a bountiful plate of fruit and pastries this morning. For today's panel, we're going to hear from North Texas Health System leaders who will share what they have learned during the pandemic, how they provide the best of care at their facilities, and what lies ahead. We're so fortunate to have them with us. It is not often you get to hear from the voices at the head of these respective organizations, and we're excited about hosting them today. But before we get into the panel, first I want to thank our series sponsor, Catalyst Health Network, and our title sponsor, RSM. They help make these panels possible. Now we're going to go to a quick message from our sponsors. So first, I'm going to kick it over to President and co-founder of Catalyst Health Network, Dr. Chris Crow. Dr. Crow, you're up.
All right, thanks, Will, and good to see everybody this morning. I'm really looking forward to hearing this conversation from our North Texas hospital leaders. I think we all have a greater appreciation of the roles that these hospitals play, given the months of waging war against the thousands of people in their facilities. I mean, it was really inspirational to watch, and I think the community really rallied around the safety net that they provide for us as a community. For us at Catalyst, the pandemic brought a lot of new things online. Got to get all of our hundreds of doctors on telehealth in about a week, and all kinds of drive-through testing sites, including those in South Dallas where there's healthcare deserts to help with some churches to do some testing, PPP loans to keep all of our practices afloat, daily webinars, care alerts, things that went national to really help these practices navigate the difficulties and keep all of our patients around the community, the millions and millions, healthy so they don't have to flood the hospitals during this difficult time. We're currently about 700 North Texas PCPs. We got another few hundred in East Texas and Central Texas, and we utilize an advanced care team model with technology to care for about 1.2 million lives. A good example of that is that over the last 5 years or so, we've saved about $75 million for employers and citizens in North Texas. You know, we have a saying around the office right now, and really all the time, that every dollar wasted in healthcare is not spent on something else. And that could be teachers and jobs and roads and philanthropy, and more importantly, maybe in our homes. And so the next 5 years, we really hope to move those dollars upstream to invest more and more in advanced primary care and public health to create a really true return on that investment that's going to produce healthier children that we can educate, healthier adults that'll be better for our workforce of North Texas, that ultimately yields to a better community, help our communities thrive. You know, this pandemic, I really look forward to today and hearing what these hospital leaders have to say. I'm really curious how they think about the future. You know, we have a healthcare system that has been highlighted for a while, but the pandemic certainly has shown that we have a lot of issues in it that we need to solve. And COVID really brought the future to us with some new opportunities and transformations. Our communities really need a healthcare system that's transformational. We deserve a system that rewards better health rather than more sickness, that actually is affordable rather than one that's the most costly in the nation. And lastly, we need one that's more equitable for all citizens, regardless of their race or their zip code or whatever their demographics may be. So I'm excited to hear what they have to say, and excited to work with them in the future to care for the millions of North Texans and see how we can really help our communities thrive. Thanks, Will.
All right, thank you, Dr. Crow. Appreciate your word and the good work y'all are doing. And so now we have a message from RSM. We have a senior manager from RSM, Anthony Placencio.
Thank you, Will. Good morning, everybody. So there's a lot of familiar names on the list of attendees. I was hoping to see some faces, but it's great to see everyone. Although I think we're all getting more and more comfortable with this virtual format. I, for one, am certainly looking forward to the next time we can spend some time together in person. So for those of you that don't know me, my name is Anthony Placencio. I'm part of the RSM Texas Healthcare Leadership Team. And if you don't know RSM, we're the leading audit, tax, and consulting firm and focused on the middle market. We serve well over 3,000 healthcare institutions across the nation. And just like everybody on this call, we've been absolutely committed to continuing to move forward, doing the best we can to not let this pandemic slow us down, and really continue to thrive. We're thrilled to partner with DCEO and Catalyst to host this virtual event. I'm sure you all are excited as I am to get to our panelists. So, I mean, the last thing I really wanted to say was just a big thank you to Will, Bethany, the team at D Magazine for keeping us informed, putting such great content out on a daily basis. So I know we all appreciate that. And thank you to everybody on the call for everything you do in the healthcare space, always, but especially now. So with that, thanks for joining us. Excited for the panelists. Back to you, Will.
All right, thank you, Anthony. So we'll hop into some introductions and some quick housekeeping before we get into the panel. So we like it's been mentioned before, right? The pandemic has changed the healthcare industry in myriad ways. Health system leaders that we have on the panel have been forced to make quick decisions about treatment, facility use, patient flow, preventing the spread of an infectious disease, all while responding to kind of constantly changing federal, state regulations impacting care. It's been a difficult time, but also a kind of an interesting and dynamic time as well. The healthcare industry needs to use data and science to make changes, and those quick shifts the hospital and other facilities have made have been impressive so far. So now I want to introduce our panelists. So we're fortunate enough to have Errol Akhtamar. He's president of Medical City Healthcare, and he has been in his role since 2010 and has been with HCA Healthcare since 1993. We also have Barclay Berdon. He's the CEO of Texas Health Resources. He assumed his role in 2014, has 30 years of service at Texas Health. And lastly, we have James Scoggin Jr. He's the CEO of Methodist Health System. He took his role more recently in April 2019 and has had leadership roles with Humana, Methodist Health System in San Antonio, and HCA. Welcome, gentlemen, to the panel. Before we begin, for all of our audience members out there, please know that we will be doing a Q&A section from you all at the end of the event. So if you want to drop some questions into the chat, I'll be reading through those and trying to curate and pull some that I think will have a wide appeal. So that'll be the last 15 minutes. So as the speakers or myself are talking, feel free to drop a question in there. And we will probably about 8:45 shift to a Q&A with the audience. So we're going to have a few questions for all the panelists. Mr. Akhtamar, we're going to start with you on the first question. So start off by telling us, what are two things that you've learned about running your hospital system during the pandemic?
Great, Will. Thank you very much. First of all, thank you to you and to DCEO and to my colleagues. I think this is a great opportunity for us to maybe even a little therapeutic to debrief on what we've gone through for the last 3 or 4 months, and certainly a lot of lessons learned. And so appreciate the opportunity to visit with you guys. When I think about two things that potentially I've learned about our health system, the pandemic is an unprecedented time that brought with it unprecedented pressures and urgency. And while I do believe that we are a high-performing and we're a high-performing health system that could move with pace and execution, I think I saw that really in spades in the pandemic, where issues and challenges were coming at us so quickly. Our typical cycle of improvement is to study an issue, is to make a plan around action, to implement our plan, and then to evaluate how the plan is working. And that, if we're lucky, happens on a cycle of months. And what was happening within the pandemic is it was happening within a cycle of hours. And so within Medical City Healthcare, within our parent company, HCA, I was just infinitely impressed with the ability of our leadership teams to analyze a problem, to develop a solution, to implement that solution in real time for the benefit of our patients, for the benefit of our communities. And I will tell you, we're blessed with fantastic healthcare in North Texas, and collaborating with my colleagues on the phone and the other major health systems, I watched their organizations do the same thing. And so one of the things I learned about my health system and about healthcare in North Texas is just our ability to step up to new and sizable challenges. A second thing I think I would say is just the resiliency and the strength of our team at all levels, whether it's our frontline caregivers that we're dealing with unknown, a new clinical situation with some personal fear and trepidation, stepping up and caring for our patients, maintaining compassionate care in an environment of difficulty and challenges. I think our leadership teams, as I mentioned, I watched them step up from our O teams at the hospital to implement and to give feedback on challenges within their systems that informed our health system and frankly informed our entire company of 180 hospitals. It was a very iterative and engaged process. And I was just, as the pandemic continued for weeks and then months, and now, we'll be with this for a while, just the resiliency and the strength of our teams, to include our physician partners who also stepped up in new ways and problem solving in real time. And Dr. Crow talked about his organization and the ability to accelerate telemedicine, which I think was infinitely important. So those are just two things that come to mind. And lastly, I'll just say the need for communication at all levels in terms of what was going on through the pandemic, but also why we were making certain decisions around visitation, around universal masking. And so communication sort of overlaid for me all of that, and was a critical. I knew it was important, but infinitely more important when the uncertainty and the risk is high. So thank you.
Yeah, that's great. Thanks for the answer. Now we'll go to Barclay. Give us a couple things that you've learned during the pandemic.
Thanks, Will. I expect you may hear a lot of things that are similar across the three systems that are represented here today. But one thing I'd like to say is that Texas Health and really the other systems that are present today are more than just hospital systems. So when we faced the pandemic, we were doing it with hospitals, clearly a focus for us. But we had also to manage 200 different, more than 200 physician offices in our Texas Health Physician Group, dozens of surgery centers and imaging centers. So we really were dealing across the complete spectrum of healthcare access and delivery. But I am so proud of how our team came together and really responded. We had a phrase that we called one team, one fight. And we were able to respond to the needs and issues in an extremely fast and coordinated way, much the way that Errol described it with Medical City. What we've learned is that when we're really focused, we are unstoppable. We can learn, move, and change quickly. And we really want to expand and grow that discipline as we move forward. The second thing that I'd note is because we had families in hospitals, patients in hospitals that had restrictions on visitors, I was most impressed, really blown away by the commitment of our staff, nurses, and other employees who really took on the extra role of being the family support while patients were in the hospital, being the caregiver, playing a support role, and being essentially a person who was responsible for keeping the communication between the family and the patient going forward. So those are two things that I would point out that I think were learned and really great about running a healthcare system during this pandemic.
Yeah, thanks for that. It's a good word about your employees, and we're going to dig more into sort of how the systems serve the employees are serving patients here in a little bit, but that's a great point. So we'll go over to Jim. Tell us a little about what you've learned during the pandemic.
Okay, thank you very much, and good morning all. Following Errol and Barclay, certainly we've had some similar experiences within the Methodist Health System. I do echo everything that both said, but I won't repeat it in the interest of time, but just add a couple of things. One is that they've already mentioned the importance of communication. I think that We learned timely, transparent, kind of sincere, earnest communications to our staff. As importantly is we learned even when we don't know, don't act like you know. And I think that that basically communicating those outstanding issues, what the status is of what we're trying to accomplish. It was a minute to minute, hour to hour, sometimes sort of change and deliberation among the health department and the CDC and things that, and from the county judge and other other directive we got, where we had to change on a dime at times, literally, and communicate those things throughout the organization. I've said to our group, and something I'm very proud of is that we had to extend a lot of grace in this process, and we had to be extended a lot of grace in this process because there were mistakes along the way or just communications which were based on the best information that we had that we then had to abruptly change because of whatever dynamic might have been occurring. I think that the second thing I would say is that in a broader sense, I just want to echo something that's already been said, and that is, it really has been gratifying and impressive to see how the health systems supported each other and have collaborated together. I can't tell you how many times there were phone calls back and forth between Barclay and me and Errol and Barclay and Errol and me. And we, you know, there was a complete openness about sharing. Okay, what are y'all doing? Hey, let me send you what we're doing, and vice versa. And that is just, I mean, it just says what a respectful, collegial and supportive type of relationship. All, you know, of course, we're competitors at one level or at several levels, but most importantly, we're all here to serve the communities and the patients that we serve and our staff and to lead the right way. And to, it's not surprising, but gratifying nonetheless to have seen people, you know, rise above all else and just completely support one another. And then the last thing I would say is that trust among, that hasn't already been said, is I think trust among the team has been absolutely critical. You know, trust can either make you or break you. If you don't have it, you can break down very quickly in this type of dynamic situation and challenging situation. And if you have it, it can make you stronger, and it can actually deepen those relationships, deepen that ability to work together. And it's just been, very, very gratifying.
Yeah, thanks. That's a good word. I like what you said about extending grace. I think that's something that definitely all industries are experiencing. I know my boss has had to extend me some grace while I was, you know, at home with 2 toddlers screaming in the background. So it's always good to have that attitude. Speaking of extending grace, wanted to talk to you guys about kind of difficult decisions you've had to make during the pandemic. So we'll start with you, Barclay. Tell us about what was maybe the most difficult or the hardest decision that you've had to make over the past 6 months or so.
Thanks, Will. You know, I would say the hardest decision for me was kind of a personal one, and that's because I'm in the high-risk age group and I have a chronic condition where my immune system is a little bit challenged. I had to stay out of our delivery sites and only really communicate like this and through videos and other things. And that was probably the hardest decision I had to make, because I'm the kind of person that likes to go out and visit with people and you know, walk the halls and go to a physician office and ask them how it's going and you know, just see people. So I'd say that was the hardest decision I had to make. The easiest decision I had to make was really directing the organization to make sure that we had adequate PPE and that we were able to keep our staff and our patients safe and that we could really keep all of our staff employed through this process.
Yeah, thank you. Thanks for sharing that. I know it's got to be tough to stay away from the people and the job that you love. So appreciate you sharing. Jim, how about you? What's a difficult, or what sticks out to you as one of the more difficult decisions you've had to make through the last 6 months?
Well, I think one of the easiest to make, but the toughest to accomplish was, as Barclay's already pointed out, is the PPE and the ventilators. And there was a time when, based upon the various models that were out there suggesting what the surge would look like and what the volume of patients that we might be caring for would look like, is as system CEOs, we all looked at those projections and said, wow, you know, it was a staggering number, and it was an overwhelming number that we were looking at, and thankfully did not entirely come to fruition. And we've been able to, I think, manage very effectively as a healthcare system. But PPE and ventilators, rounding those up, assuring that we had adequate levels. There were times when it was nip and tuck along the way. You know, we always had adequate PPE, we always had adequate ventilators, but the demand at times, or the supply of those based upon the demand, was somewhat precarious. But certainly we worked that out. I think not a difficult decision, not as necessarily a difficult decision, but probably the most consequential set of decisions we made is we spend a lot of time within Methodist. Every time we communicate, everything's based around the Methodist family. Dear Methodist family this, and dear Methodist family that. And so, you know, in the best of times, that's kind of an easy concept to get your arms around. But when you really do hit a situation where investments have dropped by staggering levels, when we've had to shut down our elective schedules, when revenues for each of the health systems, and we all face these problems, when revenues for the health systems decline significantly. And at one time we had, in our particular case, hundreds of people at home basically with nothing to do, that they could not do their job or any portion of their job from home. We really soul searched and asked ourselves, well, in the context of the Methodist family, you know, even in a pandemic, even in a situation like this, how do you respond as a family? And so there were things that, some of which everybody did, some of which were unique to the health system. Nobody went without a paycheck. We implemented premium pay, which was at a time of particular uncertainty. And I think that overall, we had to, at a time when we didn't know what kind of relief might be coming from the federal government through the CARES Act, we had to make those decisions at great expense. But we've not laid off an employee, not one. Nobody went without a paycheck, and we're very proud of that fact. And we also implemented some things that reassured staff through the most uncertain times until we were learning how most effectively to treat these patients and what the protocols should be, et cetera. We had a transition period where that reassurance to our staff was very important, and we've gotten great feedback with respect to that.
Great, thanks. And Errol, how about you? Tell us about a difficult decision that you've faced over the last 6 months or so.
Yes, thank you, Will. To my colleagues' comments, I think there were a number of difficult decisions that we were making on the fly. I think that one that comes to mind for me was the second time that we voluntarily suspended our elective inpatient and outpatient surgery. And the situation at the time was that in I guess April, there was a mandate with the looming COVID surge for us all to suspend elective procedures, and that surge didn't come to fruition, so we were allowed to then begin to do those procedures once again. Unfortunately, COVID began to rise, and we had a backlog of the patients that didn't have access to that care when we had suspended, which began to tax our healthcare system. And we heard a lot about capacity and the availability of beds and ventilators, and really what it was for us was more the availability of the staff to surge up to that level of appropriate care. And so we were approaching the point of really needing to make a decision regarding how we would be positioned. To Jim's point, we were seeing acceleration day over day, and we were 4- and 5-fold where we were 2 weeks before. and the doubling rate was at about 4 days. And so we took a very conservative position, and out of abundance of caution, and I called my colleagues, and at that time we were the only ones that were in that specific situation relative to staffing. The other thing we had the benefit of was looking at other markets throughout the country. Being part of HCA, we're in 40 different markets, heavy presence in Florida and Texas, and we were watching in Florida, in the Miami area, or in Houston, or in the Valley of Texas, where the saturation was at such a point and happened so quickly that they, in hindsight, would have made a decision earlier to suspend elective procedures. And you may ask, well, why would you suspend that? Well, there is a labor force that then begins to be available to help on the inpatient side, in the medical surgical, or in the progressive care unit, or even in the ICU, as an extra set of hands. And so it was a difficult decision because it impacts our patients and their access to care after already being suspended for some period of time. It impacted our physicians, their ability to care for their patients. We're the setting where they come to care for their patients, and they rely on us. It affected our clinical staff, because folks that were doing their normal jobs in a prior setting were now being asked to go in and give assistance in a different setting. And then financially, it was a real challenge. As we'll talk about maybe later in the conversation, is the suspension of elective surgery in an outpatient is a financial disruptor to our health systems. That is one of the areas that we rely on for the margin to carry our entire system. And so that's what made it a difficult decision. I think it was an abundance of caution. We were able to move back into, and we're better positioned with COVID kind of flattening out and then eventually decreasing, and then the ability to bring some contract labor into the market. We began to be better positioned and more comfortable with our ability to step up and rise to the challenge in a safe and adequate way within a couple weeks. And so we were kind of back at it. But it was a difficult decision. It was one born out of conservatism, but I think it was the right decision, and difficult nonetheless.
Will, this is Jim. I'd like to add just one thing that I know Barclay and Errol would agree with, and that is one of the toughest decisions that we had to make was the severe restrictions on family members being able to be with their loved ones. In that we had to require no visitors for the longest period of time with respect to our COVID patient population, and severely cut back and even limit, in many cases, no visitors there as well. And to think about the importance of family members in that healing process and that support that our patients need, and that families can provide, to have to limit that to the degree that we did and have was one that I probably lost as much, if not more, sleep over than anything else that we had to do. And I know my colleagues would share that because we just recognize how significant that is.
Yeah, that's a great point, and a good segue to actually to my next question. As the staff, as you guys mentioned before, the staff were often serving as, like family. They're really the only ones that we're able to be in contact with a lot of these patients. And in addition to an already sort of stressful and important job, now they're serving this new role as really the only interaction that a lot of these patients have. And so wanted to ask each of you guys sort of what sort of how you prepared or cared for, or sort of thought about the mental health and just the emotional health and the stress for your employees. You want to talk a little bit about some initiatives and some of the specific things that you guys have been thinking about, or that the systems have implemented during this time to care for your staff. So Jim, you want to start us off with that one?
Well, I think the staff has just done heroic work, particularly those frontline clinical folks that are there caring for these patients. It's been an inspiration, I think, to the leadership team, and certainly to me. One of the first things we did is we said, we don't want anybody worrying about their paycheck. And so we communicated our pay practices, and we communicated our payroll protection plan very early on in this process once we decided, and it did take us a while to make the determination of what was the best approach to that. And so we didn't want folks scratching their heads and saying, well, not only am I worried about the pandemic, not only am I worried about the risks that I might be taking, but if there's not enough for me to do, particularly when we had to and needed to shut down elective cases and procedures, we didn't want folks worried about whether they were going to have a paycheck or not. So that was number one. The secondly thing, and then a number of other things that we did was to communicate. We've already talked about that, so I won't belabor that point any further. We did set up a hotline so that employees could call and get answers to their questions to the degree that we had answers to those questions, whether it related to a potential exposure, whether it related to anything that they needed access to from an information perspective. We did stand up a hotline, and if I'm not mistaken, it continues today. Our pastoral care staff, which is just a superb group of and caring group of folks, they provided daily devotionals for week after week after week, provided daily devotionals that, based upon the feedback I got, provided considerable, was of considerable comfort and considerable support. Now they've stepped back on that and are now doing weekly devotionals, but still just as meaningful nonetheless. We have had virtual employee support groups that have allowed folks who might have a particular issue or might have just want to be a part of a group and have an opportunity to voice their concerns, the emotions that they were feeling, and hear from others. That's always a helpful process. We did a lot of work from home, and we'll talk more later, I think, about work from home, but we did have a lot of folks working from home and to minimize the risk, but also continue the operations. And, you know, I always say in healthcare, you either serve the patients and directly provide care, or you support those who do. And so we had a lot of folks working from home, continuing the operations of the Methodist Health System and continuing to support those who did and do provide care, but just from a different venue. We did provide some subsidized daycare and continue to provide that to the degree that we can. A few surprises along the way that we provided at times when we thought thank yous were in order. And so you can never say thank you enough, and you can never say it adequately. And we expressed that, but we also said we're never going to quit trying in that regard. And so just because you can never do it adequately doesn't mean we shouldn't try. And the last thing I would say is lots of food. Feeding folks never hurts. And so we had so much support from the communities, the towns that we're in, the communities that we're in, support from board members, support from our own foundation and others who made sure that the only people gaining weight were not those that were working from home, but rather we made sure that everybody got fed well. But it's been an inspiring period, and that's just a few of the things that we did.
Yeah, that's great. Thanks for sharing. Yeah, Errol, we're going to talk a little bit about kind of caring for your staff and employees and caregivers at Medical City.
Sure. I think early on at Medical City Healthcare and within HCA, the immutable goal was set of protecting our caregivers so that they could care for our patients and for our community. And I really think, as Jim talked a little bit about, is that's really twofold. That's clinically protecting them, but that's also personally protecting them. Under the guise of clinical protection, I think about what Barclay talked about adequate access to PPE, ensuring that the protective equipment is present, it's available, it's appropriate, that we're following the CDC guidelines in the most conservative manner. And so I think about that as a level of protection clinically. Early on, universal masking, while it turned out to be a much larger influencer of the spread, I think, as we moved into the pandemic, early on, I think all of our health systems moved quickly with universal masking within our facilities as a way to protect our staff and our caregivers and our physicians. We have had policies like hoteling, where we would pay for hotels for our caregivers that were caring for COVID positive patients that frankly had fear about going home and being around their families, an elderly family member or children. And so that's protecting them clinically. From a personal standpoint, Jim talked a lot about this, but we're very proud, and I think those on the health systems on the call may all be able to say, you know, we had no layoffs and no furloughs through a very difficult and uncertain time and a financially challenging time. And so we instituted across Medical City Healthcare and across HCA pandemic pay, where, as Jim said, those that we may have shut down the service and they may have been at home, but they didn't have to worry about drawing a paycheck. We instituted quarantine pay for those that weren't able to work because there was an exposure, either a suspected exposure at work or even within the community. We paid those individuals during the time at which they needed to be quarantined. Then the last one I'll just mention is we have a fund within HCA that was established actually back during Hurricane Katrina called the Hope Fund. And the Hope Fund is a fund that raises funds from employees for our employees. And it's a hardship fund. And as we moved into the pandemic, we recognized the need to care for hardship within our employee base. And there was $3.5 million raised, $1 million matched by the Frist Foundation, another $1 million matched by HCA Corporate to bolus this fund so that funds would be available and allocated out to those that were going through hardship. So those are sort of the things that come to mind for me in terms of a lot of other things were done, but just ensuring that we cared for those that were caring for our patients in our community.
Yeah, thanks for sharing. Barclay, how about Texas Health? What does caring for staff look like for you guys?
Well, I think I won't go into great detail on repeating some of the things that were said by Jim and Errol. You know, we did create new ways to care for our teams as they worked to care for the communities, offered a variety of support options for employees, childcare, school support resources, hotel rooms, shower facilities, and that kind of thing. We also supported, I think, really concentrated on supporting mental health and well-being, particularly given the prolonged period of time and the stress that people were experiencing both at work and away from work. We've really enhanced our virtual employee assistance program, and including psychological first aid, counseling, self-care check-ins. A lot of that is delivered virtually now, and encourages employees to share their stressors and coping strategies. And they were done twice a week, and they're actually so popular that we're going to continue them even post-pandemic. The last thing I'd say, and probably the most important thing, is really to listen to your employees. So we did that a number of ways. We polled the general employee population to ask what their concerns and their needs were, and were able to identify things that we could do. But also just having a dialogue, listening to what were people's concerns, what were their questions, how could we explain policy changes and those kinds of things, is probably the single biggest thing you can do to really serve your employees well during a very stressful time. You can't communicate enough.
Mm-hmm. Yeah, great point. Okay, cool. So time is really flying by. So we're going to hop into some kind of questions directed at each system. So we'll start with you, Jim. This question is just for you, but you know, Methodist Health is the only here in DFW is the only health system that's really headquartered in Southern Dallas, and so that kind of puts you, and you know, you also have Methodist Charlton in the area. You know, you are especially connected to a lot of the communities of color that are the groups that are most highly impacted by COVID-19 and some of these other health disparities and inequality that are there. And this also kind of comes from one of our audience members who sort of asked the same question, but what have you learned about the community you serve, and specifically some of these communities of color during this time?
Well, for anyone not familiar with the Methodist Health System, we have the only two hospitals. Two of our hospitals are the only two hospitals in the southern sector of Dallas. Of course, Parkland is an immense safety net hospital located just to the north, and of course serves a wonderful purpose. And then all of the systems serve those communities to some degree or another. But we don't just view the southern sector of Dallas as communities we serve. We really we are an integrated and inseparable part of those communities because of where our two largest hospitals are located. Many of folks that work at our hospitals live in those communities, and so we don't just serve those communities, we are those communities. And we've been there for 92 years, since 1927, and then Charlton since 1975. And it's just, it's a special mission, it's a special calling. These are special communities, and our relationship with those communities is very special. I guess one of the things we experienced firsthand relative to serving the southern sector of Dallas is the disproportionate toll that was exacted on the least served communities, particularly the African American community and the Hispanic communities there in the southern sector. You know, the incidence rate of COVID-19 and the effect that it had on those populations, the increased mortality, and because of some of the comorbid conditions or the increased prevalence of comorbid conditions and the impact that had. At one time, I think at the height of the COVID-19 census within the Metroplex, and you can imagine the dozens and dozens and dozens of hospitals within the 4-county Metroplex. If you look at the COVID-19 patient population that was being served by the two southern sector Methodist hospitals, along with Parkland, those three hospitals out of dozens and dozens and dozens were caring for about 1 in 5, not exactly, but about 1 in 5, give or take, of the COVID-19 patients. And that's specifically related to the impact that it had on those communities of color, and so we were proud and are proud to continue to serve in a special way, and so, but we've seen it firsthand, and we see, you know, you read the articles and you hear this is what's happened and there's that study, but when you look at your own data, it really hits home, and you realize the disproportionate toll. I think that as we've moved more and more through the years, but in particular, even during the pandemic, as we've moved more and more toward outside of our four walls and toward those communities with COVID testing sites, with primary care and specialty clinics and so forth, I think that the pandemic and that knowledge combined has highlighted the immense needs that are out there, and that even without the pandemic, that the needs in the southern sector and among some of these communities has never been greater. I think a third thing that during the pandemic has been highlighted to a greater degree is the racial disparity and injustice and inequities that really have contributed to the health conditions that are in these communities, not just health conditions, but a lot of other disparities, whether it be, you know, whether some of the kids are reading at a 3rd grade level compared to different communities and less diverse communities. And so you could just, there's not even time to go through that laundry list of disparities that exist out there. But it has driven home to an even greater degree that it is not a level playing field, and that we need to do more, we want to do more. And to that end, we have invested heavily in our facilities in the southern sector. I would be proud to pick any one of those facilities up, any one of those teams up, and move them anywhere in the country, and they would be successful. we would be successful in that regard, both in terms of the caliber of the facilities, the caliber of the staff, the type of care that's provided, and the southern sector of Dallas deserves no less, and we're intent on making that happen. We will be expanding, or actually replacing, our emergency department down at Charlton to the tune of about $71 million. And that's just an example of continuing to accelerate, to expand, to provide those communities exactly what's needed. We've learned we want to do more outside of our four walls, that we need to listen better. I think that anything we might consider, the communities know better than we do exactly what will work the best and what's necessary. And our real hope over time is that we can move more and more outside the four walls of our hospital, and hopefully even in collaboration with the other health systems, employers, foundations that are out there, to maybe, just maybe, pool our resources to do things continue the collaboration, continue the momentum that we've gained through this process. And the need is so great that if we aggregate and maybe do things together, we can do more and move further and further upstream towards some of those root causes. And so I'll stop there, and but hopefully over time we'll see more and more effort and more resources appropriately placed to help those communities.
Yeah. Thanks, Jim. Appreciate it. Want to go to Errol now. Medical City, obviously part of a national system, as you mentioned before, puts you in close contact with a lot of other hospitals all over the country. Can you tell us just a little bit about sort of how that network impacted operations in your system, specifically during the pandemic, and some of that information sharing?
Sure. I do think being part of HCA Healthcare, we were uniquely positioned to leverage size and scale for the benefit of our patients and the benefit of our communities. Some of the ways that took place, I think being as large as we are and having as robust a supply chain as we had, I definitely saw some benefits of the depth of supply chain when we were trying to access whether it was PPE or reagents for some of the testing that was scarce. So I think that's benefited us, benefited our communities and our patients. One of the main things that I saw was just the access to real-time learning and information with 40 different markets, with the COVID either peaking or waning in those different markets, with responding to challenges. It was a real learning lab for us, and we had the ability to communicate those learnings in real time throughout not just our company, but I'm proud to say that my colleagues and I were on calls up at a frequency level of up to twice a week, where we were on the phone for an hour, just talking about the challenges we were facing, talking about the solutions that we had implemented, and in a very open way, as Jim said, sharing very dynamically what we were learning. And I endeavored to bring to that table some of the learnings and some of the observations that we had across our 180 hospitals and our 40 different markets. I'd be remiss if I didn't talk about the CMO collaboration. Our chief medical officers likewise were on a phone call having much more clinical and in-depth conversations than we could have as executives, bringing their skill set and their perspective to bear, and again tried to inform that with learnings from throughout our company. I was proud to see our CEO Sam Hazen in the Rose Garden at the White House talking about a collaboration with the White House, where there was a time when vents and access to ventilators, if you'll remember, in New York was of a prime importance and concern. And the ventilator exchange was created, where health systems were able to put inventory into an exchange, where communities that then got short on ventilators were able to draw out of that and essentially borrow equipment to address the surges in their community. And I think that's an example of the synergy, the opportunity of taking the size, the scale, and the leverage of HCA, and not just benefiting our own hospitals, but our peer hospitals, strengthening those relationships, benefiting our communities, and benefiting our patients.
Mm-hmm. Yeah, I appreciate that. Thank you. So next question is for you, Barclay. Texas Health Resources obviously has some experience with infectious disease during the Ebola outbreak a few years ago. Can you talk a little bit about how that experience sort of was a benefit during this sort of outbreak, and were there practices that were sort of implemented at that point that came in handy, over the last 6 months?
Sure. Well, it's actually 6 years ago this month that we had an Ebola patient come to Texas Health Presbyterian Hospital, Dallas. And I guess there is a way to say that we have some unique understandings of, managing these kinds of diseases and the clinical and communication challenges that come with them. Some things apply, but they were very different situations. With Ebola, one hospital, one patient, two nurses contracted the disease. COVID-19 is, a worldwide pandemic. Its duration is far longer and poses a different set of challenges for all of us around supplies, staffing, and supporting our employees at work and home. I guess the first thing I'd say in terms of lessons learned, I've already mentioned, and that's really listen to your staff, communicate often, address their concerns and their questions, be a source of sound and reliable information and guidance to the public, and particularly to your own people. We knew from previous experience that guidelines and protocols would change rapidly and need to be adapted to our specific environment. I also had a phrase back then that was things move from science to social science to science fiction. And we saw a lot of that happening and probably still happening with this current pandemic.
Mm-hmm.
We also recognize that the CDC is an important institution, but the CDC does not take care of patients. Mm-hmm. We take care of patients. So we didn't always follow the CDC's advice when we thought it was counter to what we needed to do to take care of patients. But we instituted a team early on to daily review clinical and safety requirements and recommendations that were coming from a whole variety of directions, and most importantly, determine how we would implement those at Texas Health. We learned the importance of having stockpiles, appropriate levels of PPE, and relationships with stateside suppliers. We created those back then and have maintained those. We went into this pandemic with a diversified supply chain for PPE, and it really served us a great advantage. The other thing about the Ebola event, in reviewing it with the board of the system, it really reinforced that things that you don't think are necessarily going to happen do happen, whether you want to call them black swan events, things like that. And you have to be able to withstand catastrophic and unplanned events. So in 2015, our board approved a financial sustainability policy that really allowed us to maintain a strong balance sheet and ensure that we had liquidity and we had agility during the financial headwinds we've experienced during this time. Mm-hmm. And that allows us, to really focus 100% of our efforts on taking care of our patients and our employees.
Yeah.
Excuse me.
Yeah.
So the last thing I would say is coming together, doing the right thing for patients, for employees, and the community requires, I think, something that isn't written in a manual or a textbook. It's really living the values that underpin the culture of your company. Stick to your core principles and values in stressful situations, and they will guide you through.
Yeah, that's a great point. So we're going to shift to audience questions, and we might, if it's okay with you guys, stay a little bit late. If you have 5 minutes on the back end, maybe just to go to 9:05. We have getting lots of questions, and most of our audience is still tuning in closely. So I'll try and kind of sum up and direct them kind of specifically. So Jim, earlier you mentioned sort of an expansion and a renovation of the ER down at the Charlton Hospital. So one question that came in, and maybe this just have you answer this one, and then I'll direct some others to some other folks. But can you talk a little bit about how the pandemic has impacted capital projects, things underway, or future plans? Can you speak to that a little bit, Jim?
Yeah, I'd be happy to. Well, first of all, the board made the decision for that new emergency department in the midst of the pandemic, in the middle of some of the uncertainties that related to that. And I think that speaks to the heart of the organization and speaks to that special calling and that special mission that we do have, particularly in the southern sector, but throughout the Metroplex. From a capital perspective, we did not delay or reduce any capital spend with respect to the Methodist system. As a matter of fact, as we contemplate moving forward, our board's already approved additional routine capital and a number of other projects that are on the drawing boards that we will continue on. So I can say very directly that it really has not impacted our capital spend at all, or our continued plans for assuring that the needs of our facilities are met, and assuring that where expansion is appropriate, that we would do that. I think that one of the things that I mentioned a minute ago, this notion and idea that we would do more outside the four walls of our hospital. I think you will see us do more in a very tangible way. Barclay mentioned the strong balance sheet. If you're ever going to put your strong balance sheet, we did during the pandemic and have, but also to support our employees, to make sure that we've cared well for patients. But I think you will also see that we will take some of that resource that we have and some of the strength we have as a system, and that we will do more. We will do more. We've just seen too much need highlighted and exposed in this process, and we will move forward in that regard too. So hopefully with some exciting plans. We did not step back from recruitment efforts at all. As a matter of fact, during the pandemic, we've actually recruited more people during the thus far throughout the pandemic period than we did this same period a year ago. Our view is that we will get through this. We will need all the people that we have, thus protecting and reassuring the staff that we had, but also continuing to accelerate those levels. And one of the we have experienced probably the lowest turnover, and we were already approaching that as a health system, but during the pandemic, the lowest turnover we've ever experienced as a health system. And we're very proud of that. I think it speaks to our leadership group, the communication, the relationships. So we're very proud of that fact.
Mm-hmm. Thanks. Yeah, I appreciate it. And this one's for you, Barclay, and it's kind of a question that's come in a few different forms from different sources, but just thinking about some of the changes that have been made during the pandemic, specifically around technology, interacting with patients, shifting ways that providers are interacting with patients. What do you see kind of going forward? Do you see some of those changes remaining kind of permanent? Is this a permanent shift? Is it going to go back? And what has Texas Health sort of done to deploy some of these technological resources to interact with patients?
Sure. I think what's happened in our system has been true in many systems. We've adopted digital technology, a lot quicker than we had planned. We, like has already been mentioned by Jim and Errol, in a matter of a week or two, we're able to launch a substantial amount of virtual care. And most people, I think, would tell you that they think virtual care is here to stay. And I believe it is. So I think that's one big shift that will happen. I think we'll continue to see it kind of ebb and flow, and the technology will continue to improve. Part of that will be driven by the payment policies. So right now, I think Medicare's policy and many of the commercial payers are paying an equal fee for virtual or face-to-face E&M care in a physician office. And I think as long as the reimbursement policies continue to support that, we're going to continue to see more deployment and adoption of virtual technology. I think we're going to see the inventory management systems change pretty dramatically. Most of us were kind of using a just-in-time system where we had just the inventory we needed. There was a lot of analytics behind that, but a truck would basically pull up the night before with pretty much everything you were planning to use. I think we'll see more local inventory stockpiles, both at health systems. We may see it from a government point of view, and I also think related to that, we're going to see a move to onshore or nearshore more production and distribution of supplies and pharmaceutical materials. Mm-hmm. Lastly, I'd say there were a number of regulatory changes that were made under the disaster declarations. And a number of those, I think, have great merit. And so we hope some of those will not pop back to the way they were. A lot of those are around telehealth technology, particularly in behavioral health, furnishing those via telehealth. So some things like that, I think, will continue and grow and will fuel change in the future.
Great, thanks. And Errol, we'll give you the last word. It's sort of a general question that came in, but I think will be sort of a revealing one. But just kind of what, going into Q4 of this year, and into 2021, what are your organizational priorities? Kind of what's top of mind for you looking ahead?
Clearly, I think we're going to be continuing to deal with the pandemic and with COVID. And so as we move into the fourth quarter, I think, unfortunately, it's going to be a little bit more of the same relative to how we're operating in response to the virus. My great hope is that we'll continue to universally mask, to social distance, to do the things that are working right now to flatten the curve. And I would implore all of you to communicate to anyone and everyone you can that the measures we're taking are working. They need to be sustained until a point in time in which there is a broad application of the vaccine. And so that's my plug. But that being said, I do think we're going to be dealing with the virus on into the fourth quarter. One of the things that I think about, and I'm sure my colleagues are thinking about, is the financial impact of the pandemic. And so we, April for all of us was a devastating month financially in terms of our normal course business being disrupted. The COVID or the pandemic has brought with it its own financial challenges relative to additional cost. Barclay and Jim both talked a lot about PPE. They don't give us that stuff for free. And as a matter of fact, in an environment where scarcity prevails, the cost goes up. The clinical sort of acuity of our patients is higher. That's adding cost to the system. Protecting our workforce, which Jim and Barclay talked about as well, is additional cost to the system. What I foreshadow a bit into the fourth quarter and into the beginning of next year is what is the impact on the economy of the pandemic. We've seen how the shutdown has negatively affected the economy. We read daily about more layoffs at companies, individuals losing their employment, then losing their health insurance, becoming underinsured. I worry about the federal and state government funds, which rely on our tax base. That's driven by a robust economy. As they come up short financially, what does that then mean for the financing of healthcare at the state and federal level? It's always precarious for us in terms of having the federal and state support for the healthcare system that we need to care for our communities. I think that has the potential for becoming a potential threat to our health systems. And so I think continued COVID in the Q4 on into next year, and then really what's the economy going to do? How's that going to affect the economics of our health system? We have very strong, robust, and high quality medical care from our physician community, from the health systems, and sort of from all aspects. And I think we ought to be proud of that. And I think we ought to be dogmatic about protecting it.
Thanks. I think it's a good way to end. Sorry we ran a little over late, but we still got 130 folks hanging with us to 9:05. So thank you all for tuning in today's panel, and thank our panelists for being here. It's not every day we get such a high level view of healthcare in North Texas, so we're fortunate to kind of get that perspective today. I know for me, I know we didn't get to all the questions, but they will definitely spur on my sort of coverage ideas and gave me a lot of ideas for future stories and things to write about. So we appreciate you dropping those in. I want to thank our panelists, Errol Akhtamar, Barclay Verdon, James Scoggin, once again. I also want to thank our sponsors, our series sponsor, Catalyst Health Network, and our title sponsor, RSM. Thank you guys. And thanks to everyone who tuned in. I hope you guys have a great day. We'll get you off to your work day now, and hopefully we will see you next time. Thank you, guys.